Well, good morning, everyone. Thank you for joining us on our second day of the World Medical Innovation Forum. I'm Jason Zemansky, one of the equity researchers at BofA in Biotech. Today's panel, for which I'm very grateful to be hosting an amazing group of individuals, is concentrated on earliest detection. So recent advances and revolutionary approaches for which we can identify diseases months, years, and even decades before symptoms appear. So with that, I will let the panelists introduce themselves and look forward to a very interesting discussion. So, David?
Hi, I'm David Lewis. I'm the chair of Pathology for Mass General Brigham. And I'm also joined by Jim Brink as a moderator.
I'm chair of Radiology at Mass General Brigham.
And we'll ask each of the panelists to introduce themselves as they answer the first question. So we thought we'd frame the discussion around the term earliest. For each of the panelists who work in somewhat different areas, what does earliest mean to you in terms of your field? Are there ways that you can think in the near future of it getting even earlier? And what recent developments have contributed to this change in where diagnostics can occur? And I'll start with Heidi Rehm.
Thanks, David. So I'm Heidi Rehm. I'm a professor of pathology at Mass General Hospital and the chief genomics officer in the Department of Medicine. And I'm also a longtime clinical lab director right now at the Broad Clinical Laboratories. So with regard to David's question about how early, I'm a rare disease researcher, and so I think about a lot of diseases that affect children. And in fact, rare diseases affect about 1 in 10 people. So when I think about going how early, it's really about utilizing a genome for your entire life. And so you could argue newborn screening, which has gotten more and more uptake in terms of newborn sequencing, might be the best time to actually sequence an individual and detect the presence of diseases at birth or risk for diseases, which could also influence parental risk in detecting childhood sequencing data. Of course, as we start to do this at a newborn stage, we realize that the consent process is actually often done more easily while the couple is pregnant, so there's a little more time to think about whether they want their child sequenced at birth. And then all of a sudden you start to have the conversation of, well, why not just sequence now while I'm pregnant? I have an opportunity to intervene, whether it's to think about carrier screening or early detection in the fetus, and even being sure to be prepared for the birth of a child who may have a rare disease and being able to intervene immediately. So the short answer to the question, in my mind, is we want to start during pregnancy. That gives us the longest lead time to do something useful with genomic data. So that's my answer.
Thanks. I started with Heidi because I realized she would be the earliest. So maybe next go to Pradeep.
I'm Pradeep Natarajan. I'm the Director of Preventive Cardiology at Mass General. I have a research lab that spans both Mass General and the Broad Institute. And the patients that I see within our program it's kind of two bins. So younger patients who have had premature heart attacks that are not otherwise explained by their traditional risk factors, or folks who are getting recurrent heart attacks. And then those who are also early, young, 30s and 40s, often because of a family history, but not necessarily an enrichment of traditional risk factors, who come to get evaluated to understand their risk, to understand if they're at similar risk as family members and what they can do about their risk. In my research lab, we really just try to understand what those novel mechanisms are, the unrecognized mechanisms, and the opportunities to go as early as possible. Today, the paradigms for early risk identification focus on the traditional risk factors, and we have a great paradigm for recommending screening lipids in their 20s, but we know the process of atherosclerosis starts very early. It is the leading cause of death in the world, over the last 20 years. Complications of coronary artery disease have been the leading cause of death. We know from short-term clinical trials that the earlier you start preventive therapies, the more likely you're going to benefit from therapy. So we're really motivated to try to go as early in the disease process. And we don't have a lot of data to really understand how early it starts. Actually, the best comes from US soldiers who were killed in action in foreign wars. Among those individuals in their 20s, on autopsy, 1 in 9 has atherosclerosis. Vast majority don't have recognizable traditional risk factors at that age. So we use tools like human genetics to try to prioritize those individuals. Undoubtedly, there'll be other features as well. So when I think about earliest is, as early as possible that we can introduce preventive therapies that can maximize the opportunity for risk reduction. Because if we do it early, then we're more likely going to realize benefit, but we need the tools to better identify the folks who are at higher risk.
Thanks, Pradeep. I'll turn it over to Yakil next.
I'm Yakil Quiroz, Associate Professor in Neurology and Psychiatry and a clinical neuropsychologist. So I see patients for neuropsych assessment. My research focuses on aging and Alzheimer's disease. Especially, I study a Colombian kindred, a very extended large Colombian family that carries a single genetic mutation for autosomal dominant Alzheimer's disease. So when I'm thinking about the earliest, and it's kind of like related with what Heidi was saying, like in my research, for instance, we know that these individuals that carry this mutation, there is a mutation in the presenilin 1, they are going to develop Alzheimer's disease in their mid-40s. So what we have done in the past is kind of like a going back in time and characterize what we call now preclinical Alzheimer's disease. But for instance, one of my projects right now is to study the children and the teenagers that carry this mutation. So with the hopes, and this similar to what Pradeep was saying, of thinking about prevention and also thinking about primary prevention.
Thanks, Yakil, and certainly last but not least, Jas.
Hi, everyone. So I'm Jasmeer Chhatwal. I'm a neurologist at Mass General and the Brigham. My lab is sort of split 50-50 between neuroimaging research and looking at blood-based biomarkers. I study Alzheimer's disease and other neurodegenerative diseases. And it's a pleasure to be here. In terms of earliest detection, like Yakil, I also study genetically driven Alzheimer's disease, autosomal dominant Alzheimer's disease, and earliest detection there follows the paradigm that Heidi talked about. So prenatally and at birth. Unfortunately, people that carry these driving mutations for dominantly inherited Alzheimer's disease, these are fully penetrant mutations, so those we can detect, even before birth. But there's another peak, which is sort of towards the middle of life. So early onset Alzheimer's disease, usually ranging between 50 to 65 years old. And then there's late onset Alzheimer's disease. And each one of those has their own characteristics, their own biomarker patterns, and a different risk benefit for when you'd want to detect and when you might want to treat. So we'll get into that more, I'm sure.
Great, thank you all. Let's cut the topic from a different direction and approach it perhaps from the different modalities that are available for early diagnosis. There's certainly many imaging advances that enable earlier diagnosis, as well as blood-based biomarkers and germline genomic sequencing, for example. I wonder if we might be able to go around the horn again and ask each panelist to talk about such approaches from the advantages and disadvantages that may be, and concerns that may be associated with other modalities. Heidi?
Sure. If we think early in life, so today newborn screening is largely done using tandem mass spectrometry, but there's increasing use of genetics in follow-up to resolve those results seen in a metabolic screening, and now increasing use of genomic sequencing as a primary or complementary approach to newborn sequencing. But my argument before about going even earlier in the fetal state, there's been massive uptake of NIPT, non-invasive prenatal testing, happening during pregnancy. In fact, in the US, over 75% of women are getting NIPT. That is done by genomic sequencing. Now, it's a low-pass sort of methodology, so today it's not robust enough to routinely sequence an entire genome, but there's already been demonstration that that's possible, and people have sequenced entire genomes from circulating fetal cells in the maternal bloodstream. So in my mind, where we're headed is to take advantage, as we continue to improve the robustness of genome sequencing from fetal cells, that already is a modality that's already being accessed in most pregnancies. It would be easy to continue that path and add more and more ability to interrogate the entire genome. So in my vote, we take advantage of that very common non-invasive screening that's happening today in most pregnancies.
Thanks, Heidi. Pradeep?
Yeah, I mean, for blood-based testing or early detection for coronary artery disease, there hasn't been much innovation for the last 50 years. We're focusing on the same traditional cardiovascular disease risk factors. A major reason why is that most drug development today starts in patients after they develop coronary artery disease. As cardiologists, we spend the bulk of our time basically managing the complications after somebody has established disease. And it's much more efficient for drug development to focus on a higher risk population. Those who have not had disease yet are inherently lower risk. And that has limited the development in that stage. I think new tests for genetics, not necessarily innovative tests, can substantially transform at least the ability to do prevention. What has changed, I'd say, is the radiographic detection of subclinical atherosclerosis has had rapid advances over the last 20 years. We know that among middle-aged individuals, the best predictor of risk are age and sex, and then number 3 is the presence of atherosclerosis, non-contrast cardiac CT, the presence of coronary artery calcification. And that indicates some complexity of plaque because plaque starts off as non-calcified plaque. The opportunity for genetics is really before the onset of more complex atherosclerosis. But there continue to be innovations in CT now with contrast-enhanced CT angiography, which can also detect non-calcified plaque. There's the prospect of looking at additional plaque features as well, too, and there are many companies that are innovating on the notion of tailoring preventive therapies based on that. That's a little bit to be seen, but I'd say probably much more innovations on the radiographic side. One thing I'll add is that a lot of people are interested in ultrasound-based detection of atherosclerosis. It's used today, at least for carotid artery diagnosis for carotid artery stenosis. The presence of subclinical atherosclerosis doesn't have great resolution. There is some innovation in 3D ultrasound to detect the presence of carotid plaque. That has the, for a broad population that is lower risk, that is a lower risk test with ultrasound versus CT because there's no radiation. So there is ongoing work there. So I think at least for young middle age to mid-middle age, there'll be a great opportunity for plaque characteristics on CT and ultrasound.
Thanks, Pradeep. Yakil?
Yeah, maybe I'm going to start the answer and just pass it to you so we can complement. So for Alzheimer's disease, for instance, we have in neuroimaging, one of the advantages that we have is like neuroimaging has been moved really quickly in the past decade, and now we are able to use like PET to see the accumulation or pathology such as amyloid and tau that are the 2 hallmarks of Alzheimer's disease. That has opened a window of opportunity to actually detect individuals that are at increased risk based on the accumulation of amyloid in their brains. So another, in amyloid tau, I'm going to explain the disadvantage in a minute. So the other neuroimaging that we had used in the past is just structural MRI, right? So this is a tool that is used in the clinic to detect early atrophy or like signs of atrophy in these individuals at increased risk. The other modality is CSF that also allowed us to measure amyloid and tau pathology, and it has been sensitive to very early stages, even preclinical stages of the disease. And the other one that I can think of course, that is the one that is more advanced now and moving forward is the blood biomarkers, blood-based biomarkers that are also very promising, and of course we are getting there, and this is the part that Jas can complement. But it has a lot of promise. So some of the disadvantages, especially for the first 2, like the PET imaging and the CSF, is that they are very expensive and they are invasive. And for instance, PET imaging, unfortunately, is not available in every clinic or every center. So it is very challenging to actually get access to these measures. Also, the radiation, the patients are exposed to radiation, which I think is a disadvantage, and something that is definitely a great advantage for the blood-based biomarkers.
Thank you, Yakil. Jas?
Yeah, just to reprise some of the themes that Yakil was talking about, it's hard to underestimate how much biomarkers have changed in Alzheimer's disease and neurodegenerative disease in general. So there was a period of time where we had no ability to see Alzheimer's disease pathology during life. And that changed with the advent of amyloid PET and later the advent of tau PET. And there's another kind of revolution coming through. I don't think there's any other word for it in terms of the development of blood-based biomarkers for Alzheimer's disease. So as Yakel mentioned, PET is expensive and access is an issue. Blood-based biomarkers offer the opportunity to screen large numbers of people and elucidate something that is interesting, scary, troublesome, depending upon your perspective, which is that there's a long preclinical phase of Alzheimer's disease where people are developing pathologies. So tau pathology often starts in the 20s in the entorhinal cortex, if you can believe it. And there's a long preclinical phase where amyloid burden is elevated, and yet there's no loss of neurons and synapses. And people don't have any symptoms. So what these modalities, PET and these blood-based biomarkers have allowed us to recognize is that the disease process starts, just like in cardiology, well before the onset of symptoms. And we're talking 10, 15, maybe 20 years in some cases before you can start to see signs of these pathologies. And especially the blood-based biomarkers, because of their cost, because of the better access, I think are going to revolutionize the field. So one of the dirty little secrets of behavioral neurology is that most of the time for 100 years or however long the discipline has been around, we diagnose people based on their symptoms, their neurological exam, their family history. But actually, there's a minority of patients in our clinics that had definitive diagnoses based on the buildup of amyloid or tau. Those are the hallmark pathologies of Alzheimer's disease. And around the year 2000, we started to have access to cerebrospinal fluid testing, later PET, and now blood-based testing. And we're going to go from a phase where a minority of our patients have this testing to where everyone does, and it's going to start to move out of our clinics into primary care and into that preclinical phase. So it's an exciting, scary, wonderful time, depending upon your perspective.
Thank you.
That's a really great segue, I think, for the next question is if we could look at the discipline from the vantage point of the patients. I wanted to ask, what are the advantages and disadvantages of an early diagnosis? I'll run through the entire panelists here, but I'm curious to draw a distinction whether, for those individuals where, or indications where behavior modification could have a long-standing impact on disease progression versus some of the diagnoses that there may not be those options there. And for those that can modify their behavior, how many patients ultimately do? So maybe if I could start with Pradeep.
Yeah, so lifestyle, diet, physical activity, sleep substantially alter the trajectory for coronary artery disease risk, especially if those optimizations happen early in life. And we know from just population-based data, if you look at the American Heart Association's Life Simple 7, now called the Essential 8, which includes sleep, about 1% of the population is actually optimal on all of these. And these include the traditional risk factors as well as these behavioral factors. There is a tremendous opportunity to optimize behavior. And so the flip side of these arguments, when we talk about refining risk, some people say, we should just be doing this with it for everybody. The truth is, implementing mass behavioral modification is a very expensive prospect. I think if you're trying to allocate resources, really refining those who are at the highest risk, where this is a potential driver of risk, that's where you can be much more efficient with the resources. There is this notion that if you communicate risk, if you present risk, that itself can also be a motivator. And in studies, at least when people have signed up to receive this information, in general, that is a motivator for clinical risk. Other novel factors, including genomic risk, in single-arm studies can be a motivator as well. But actually implementing it is really hard to do. The programs that we have that are paid for, like cardiac rehabilitation, we have at MGH, is really after patients develop cardiovascular disease. And it is very effective to prevent the recurrence of a cardiovascular disease event. Wouldn't it be great if we had it earlier in the process? And I understand, obviously the cost has been the big barrier because there is another parallel. The diabetes prevention program showed for patients with prediabetes, it was very effective at preventing the onset of diabetes, and it's paid for, but for programs to stand that up also is pretty expensive to do, and not everybody has the time or bandwidth to be able to do it. So it's very complicated. I mean, I spend a lot of time, most of my time actually talking about lifestyle modifications in the clinic, but there are lots of practical steps that are individualized in the context of what patients do in the day-to-day that actually help them realize that. So there's one aspect to motivate, but then there's another very complicated aspect to help them achieve that. a longitudinal relationship that includes the physicians as well as the other health professionals are critical to achieve.
Great. Maybe Heidi, could you, I'd like to hand you the mic next, but could you talk a little bit as well about, for parents where there is an option to intervene early with, say, a genetic-based therapy versus, instances where that's not yet possible, what is a parent to do?
Yeah, in rare disease, there are a small number of disorders where you can really effectively treat, and that could be with enzyme replacement or other modalities. But for most rare diseases, there is benefit, even if there isn't a direct therapy. There's benefit of an early diagnosis because for a lot of these diseases, these families go on diagnostic odysseys for years and years and years. The other day, we diagnosed a woman at 85 with a form of muscular dystrophy that she'd lived with her whole life. And understanding what's to come in these families in terms of phenotype development is really important because they can anticipate and intervene to manage that disease. And in fact, there's a number of diseases. Some of the most common rare diseases are things like hypertrophic cardiomyopathy. You may have some familiarity with this because you tend to hear about it on the news when a famous athlete dies of it. Hank Gathers, Reggie Lewis. Many athletes hit the news having died from hypertrophic cardiomyopathy. And my lab has done testing for this disorder for many years. And we test often because the first family member dies, but then we can identify 50% of first-degree relatives who are also harboring the same mutation, also at risk for sudden cardiac death, in which you can intervene with many cardiac interventions like myectomies, intracardiac defibrillators, even heart transplant in the late stages. Same with hereditary breast cancer. You can do myectomy or bilateral mastectomy or oophorectomy to prevent the very serious consequences of hereditary breast cancer. So even though not every rare disease has a direct therapeutic treatment, there are many things that we can do in many of the 10,000 rare diseases to improve the outcomes of these individuals.
Great, thanks. And maybe Jazz, you, I think, hit it very succinctly that the advent of blood-based tests for, say, Alzheimer's, is scary. What happens to a patient who's in their 20s or 30s who goes to their primary care doctor and learns that they're, starting to develop at least physiological or if not clinical signs of Alzheimer's? What happens to that patient, and what does the doctor tell them?
So it's a complicated question, and I think the context really matters. So there's certain types of genetic information which, by virtue of complete penetrance and autosomal dominant inheritance, there's a very clear thing to say to the patient. Unfortunately, the genetic change that you have is going to lead to Alzheimer's disease at around the same age that other people in your family were affected. Then there's another class where you can talk about risk of Alzheimer's disease. So the ApoE4 gene, many of you may have heard of, conveys risk for Alzheimer's disease. It's the largest, in terms of number of people, genetic risk factor for Alzheimer's disease. So that's a different sort of a conversation because ApoE is something that's present in about 23-24% of the US population. So maybe that's the percentage of people that have green eyes. It's part of our conception of normal. The way that you sort of approach those things, I think, is very, very different. Likewise, if somebody comes to your office and they're in their 80s and they're starting to have memory loss, you pretty much know when the person comes in that it's a combination of things that are leading to this. Vascular changes, alpha-synuclein pathology like in Parkinson's disease on top of Alzheimer's disease, and it's really the confluence of all of those things that's leading to disease. So I think that there's a difference kind of in those kind of three buckets, but generally I would say that overall neurology is well behind cardiology in terms of having effective interventions on lifestyle, and part of it is that we didn't know a lot about how the disease progressed in the preclinical phases because we didn't have the tools. Now that's changed. I do think that there's very good evidence to suggest that changes in lifestyle, particularly mitigating cardiovascular risk factors, many of the same things that Pradeep talked about, is beneficial in terms of delaying the onset or slowing the progression of disease. But we don't have lifestyle interventions that convincingly change the underlying amyloid or tau pathology yet. But now we have the tools to investigate on a large scale how lifestyle might affect Alzheimer's disease. So I hope in a few years when I come back, I can give you a more concrete answer about what you can change.
Great. And then finally, Akhil, you have sort of a unique perspective, I think, looking at families where there is, a very high prevalence of neurological issues. For a patient who comes to you who may have, a family history, do you have a sense of how often they're willing to submit to a diagnostic test, and what happens if it is positive?
It's related to what Jas was saying before, we will see here and in the family that I study in Colombia too. So with autosomal dominant Alzheimer's disease, it's a deterministic mutation, they are deterministic mutations. So usually if they have the mutation, they will go into develop Alzheimer's disease. In the population at large, for instance, we know that ApoE4 is one of the genes that is considered risk factors, and that's not a deterministic gene or deterministic mutation. So not everybody that has ApoE4 will go into develop Alzheimer's disease. So with the patients, with the participants, is having that conversation of what it means, the risk, right? One thing is that you have greater risk, and the other thing is that you will go into develop, which can help to plan to make decisions in terms of family planning, financial decisions and so far. While with the ApoE4, as Jas and Pradeep mentioned, I think that the lifestyle could play an important role as we have more and more interventions. And once they start showing symptoms, as you may know, there are now 3 disease-modifying treatments that are approved for Alzheimer's disease, but they are only given to patients when they are symptomatic. So the earliest we go in the symptom presentation, the better chance they will have to benefit from those treatments.
So as we look ahead and these diagnostics become more accessible and more common, we would presume that the positive benefits would scale, but I guess I'd ask each of you to share your thoughts about that. And perhaps more importantly, if they won't scale and they won't have an expansion of their positive impacts, why not? And what would it take to overcome those limitations? Sort of stated slightly differently. What keeps you up at night about these technologies and capabilities? Or maybe you just sleep fine, and that's fine too. But maybe Jasmeer, do you mind? We'll start with you.
Yeah. Actually, sleep is a very important thing in terms of a risk factor, so it's very apropos. The things that keep me up at night are how to explain to people who are in preclinical or very early stages of disease what our biomarkers mean for them and what the risk benefit is of trying to address those factors. So in terms of lifestyle modification, that's pretty easy. I think that for both cardiovascular reasons and neurological reasons, advising changes in lifestyle is pretty important and straightforward to suggest. It's very hard to implement, as Pradeep talked about. So that part I think is okay, but how do we talk to people who have signs of disease, have no symptoms, and right now our main way of intervening on the disease is first just starting. So we have the first disease-modifying therapies for Alzheimer's disease just now coming into clinical use. We're still learning how to use them. They have major potential for side effects, and they have a lot of burden on the family, on the person who's taking the medication. So I don't think we really have a great idea of what the risk and benefit are. So there's several trials going on that are trying to use these medications in preclinical phases of disease, and it's feasible that, again, if I come back in 5 years, we're talking about primary prevention before the first event, like in the cardiovascular diseases Pradeep was talking about. So before there's any change in terms of cognition, before there's any brain tissue loss, interventions at that point, if these clinical trials bear out, maybe what we're talking about here. And what keeps me up at night is how are we going to get people access to these? Who should we treat? When should we treat?
Okay, thank you. Akhil, maybe the same question, but from the neuroimaging perspective.
Yeah, and before the neuroimaging perspective, I wanted to add from the clinical perspective because most of my patients, they are actually non-English speakers, and actually the big majority of Latinos or Spanish-speaking patients. By the time that I see them, and I'm clinical neuropsychologist, so they are usually referred by neurology or the PCP or psychiatry, they are usually already too late in the disease process. So pretty much like we miss the window of opportunity for early mild cognitive impairment. So that's something that really keeps me awake all the time, because it's kind of like, how can we actually make these diagnostic tools more available so everybody can actually get a chance, especially if they can benefit from those treatments and the window is very limited. Many of my patients, they already passed. Pretty much the treatments are already gone and they don't have any treatments available. So like thinking about how we can actually improve, especially blood-based biomarkers, that is the one that is getting more and more, getting more widely acceptable, something that can reduce health disparities instead of increasing more the health disparities that are already in the field, especially in Alzheimer's disease.
Thank you. Pradeep, maybe from cardiovascular perspective?
Yeah, I think the main issue for us is that we're just not identifying individuals early enough in life. You know, we have a good framework in middle age and mitigating 10-year risk, but so many people get premature heart attacks. And also, if you identify the folks who are going to get heart attacks in middle age later in life and you do it earlier in the disease process, the therapies that you would recommend, if initiated earlier, are more likely to be effective. I've been really excited about the use of human genetics to identify early, because you can go, as early as possible. And the tools are getting increasingly better. As I said, we have a framework for screening lipids. It's been in the guidelines since its first inception in the 1980s for screening lipids in 20s to identify folks who have severe hypercholesterolemia. So LDL greater than 190 and initiating a statin. It's about 1 in 300 individuals. Through genetic tools, these so-called new polygenic risk scores, which are basically a string of common genetic variation that's observed in the population, represented as a continuous score that gives you, your sense of what is the genetic contribution for risk. That score will be unchanged from birth till later in life, so it can be used very early. And the scores continually are getting better because we're profiling more and more individuals, more and more diverse individuals, and so the scores continue to get refined. The genotypes are the same. So that same 1 in 300 risk related to severe hypercholesterolemia, about a 3-fold risk. Today, it's about 1 in 5 that you can detect from a polygenic risk score. That's not readily detectable by any of the modifiable risk factors. So I think there is a profound opportunity to substantially change primary prevention and go much earlier. There are lots of, I think, important nuances on drug development based on this. We have actually gone back and profiled many completed cardiovascular clinical trials to say, how do people respond if they have a high polygenic risk score? Interestingly, they have a unique response to cholesterol lowering. Much better response, even though doing it earlier in life, but also the effect estimate relative to the amount of LDL cholesterol lowering. So we have some sense of what we would do, and it's not a crazy prospect. It's just starting statins earlier in life. So I think there's an opportunity to do a lot. So I spend a lot of my time thinking about what is the evidence basis that is needed to responsibly implement these in the clinic. But we're getting very close. We're starting to use these already.
Thank you. And Heidi, as our Chief Genomics Officer, I think we're all eager to hear your perspective on what will be the limitations about scaling our earliest opportunities and what keeps you up at night.
Yeah, I think the biggest challenge in my mind is when we sequence a genome, we typically do it for one reason. Maybe there's a rare disease phenotype or something else that leads us to sequence that genome, but in fact there are 3 to 5 million variants in each person's genome. And the sheer amount of information and evidence that we need to interpret all of that variation right now is unattainable in terms of doing it cost effectively and at scale, and will require an enormous data sharing effort around the globe to actually inform what all of those variants mean in each individual that we sequence. And to some extent, what keeps me up at night is not just the scaling problem, but in fact that when we sequence an individual's genome, we have that data and we're not making use of all of the other information. There is information on disease risk for later in life, both rare monogenic disorders, as well as now the ability to use polygenic risk scores to inform risk. There's pharmacogenomic information in there that guides the use of which drugs to avoid adverse events, as well as the appropriate dosing of drugs, yet that's not being utilized today. When I ask physicians at Mass General Hospital who are ordering pharmacogenomic tests for some specific drug they're prescribing, and I say, gee, why don't you order a panel for the same price? You'll get information on other drugs that patient might be exposed to in their lifetime. They say, I don't want the liability or responsibility of managing that list of drugs. And our electronic health records are largely not set up today to ingest that information and deliver clinical decision support at the point of care when the next drug is ordered. And so from my standpoint, what keeps me up at night is that our systems aren't able to utilize this information in ways to actually benefit the care of patients on an ongoing basis. And we have to scale our electronic health record structure to incorporate genomic information, as well as share phenotypes and genotypes of every genome sequenced around the world to be able to take advantage and scale our understanding of genomic variation.
Thanks. So most of what we've covered so far is a perspective from the patient's point of view and the treating physician's point of view. And what we'll take a few minutes to look at is other perspectives. So certainly the ability to diagnose earlier affects other stakeholders, for example, patient advocacy groups, funding agencies, the payers potentially, drug development, diagnostic development. So we'll just go around and think about at least some of those components. Maybe I'll just start with you again, Heidi. Think about patient advocacy groups. How do they get involved in this kind of movement earlier?
Yeah, we've been involved in a program called Rare as One that's funded by the Chan Zuckerberg Initiative, where they're really trying to bring in patient advocacy groups. And in rare disease, there's a small number of patients for each disorder. And so trying to help these organizations advocate for their rare disease, to be able to develop therapeutics, they need a lot of help and guidance. And so this program really has now brought in over, I think they're on round 3 of funding, now close to 90 different patient advocacy groups, and helping guide them and think about what to do with their fundraising, how to advocate with pharmaceutical companies for treatments for their rare diseases, because there's a lot of effort. And also we have a program that we're developing better statistics on prevalence of each disease, because the pharmaceutical companies don't want to invest money in developing a therapeutic unless they know they're going to have at least some sized market. So we, through genomic analyses, can help identify what the actual prevalence worldwide of that disorder is, to be able to inform the interest of the pharmaceutical companies in developing drugs. And so I think these are some of the factors in thinking about how this really therapeutic market develops, is really working with both patient advocacy and pharma companies in terms of informing those patient populations and what's needed.
So maybe that's a good entree to asking Jas and Pradeep a little about how you see this ability to diagnose earlier affecting folks interested in drug development, but also in diagnostics development.
Yeah, I mean, I think the major challenge for at least polygenic risk scores as a tool is one, opportunity is obviously they're very good for risk predictors, seem to have some role in disease prediction, also in recurrent disease prediction. The challenge is the regulatory framework is not totally clear. There is a good framework by FDA for pharmacogenomics, which are largely single genetic variants that could predict a differential response based on a therapy. And there's some validation for just that single SNP. That's pretty straightforward. These scores are often represented as 1 to 2 million genetic variants. They have differential weights, but together are summative. That's one. But there is no canonical score, and the scores continue to innovate. So as I said, the genotypes are static, but our interpretation continues to evolve. So I have conversations with many companies who are excited about this, are interested in planning a study, but I can't guarantee them in like 1 to 2 years there won't be a better score out there that predicts the ultimate outcome. That has been a major barrier. That's outside of my expertise, but that is, I think, what has been limiting the application as it relates to drug development. At least for coronary artery disease, some of the initial prospects for medicines would be medicines that are already out there. But there are other interesting therapeutic hypotheses. These are not trained based on differential medication response that just happens to exhibit an interaction for LDL cholesterol, but we're using clinical trial data to actually identify more pharmacogenomic polygenic risk scores. But this issue of multiple genetic variants, iterative learning, that needs to evolve from a regulatory standpoint.
Jas?
Yeah, so in Alzheimer's disease, I think that in neurodegenerative disease in general, actually, Biomarkers are absolutely critical, particularly for late onset disease. As I mentioned before, if somebody comes in, they're in their 70s, 80s, 90s, it's very likely that what's affecting their cognition, their memory, is multifactorial. And understanding those factors and what that mix is sets the boundary conditions for what treating one part of their disease, amyloid for instance, what you're likely to get in terms of benefit. So it's critically important that we understand the reasons why people may have cognitive impairment, because there's so many, and the treatments are really directed at one proteinopathy, one protein buildup, amyloid in this particular case. And early on in the development of anti-amyloid agents, it was very common in clinical trials to use just cognitive screening for getting people into testing. And that proved to be a huge, huge problem, because a substantial percentage of the people that were treated actually don't have Alzheimer's disease. Now we have the tools to understand who we're putting into the trials and understand more about the disease stage. So I think it's absolutely critical. And then in late onset disease, understanding what mix is present so that you can decide, is it worth it to treat someone?
Thanks. And Yakil, there's obviously a lot of excitement about all of this work, and it's starting to filter into the people who fund this kind of work, whether private foundations or NIH. What have you seen in terms of interest from the funders about this kind of early diagnosis work?
There are two things. The blood-based biomarkers is of the high interest. I would say, like the foundations and also the federal agencies are very interested in developing that further and like validate and standardize the approach, even creating some guidelines. So for clinicians, so they can actually use it in the clinical practice in the future. So I think there is a lot of movement in that sense. The other part that I'm very glad to see is also in terms of like increasing representation, and how, like, for instance, traditionally most of the clinical trials or even like the drugs that were developed for Alzheimer's disease, for instance, most of the sample is like white individuals, right? So now there is a call for making more inclusive research, and knowing, especially in the US, that African Americans and Latinos are at greater risk to develop Alzheimer's disease and other dementia. There is a particular call, which I'm very glad to see, or making clinical trials and research studies more inclusive.
Well, we have about 2.5 minutes left, and in that time I'd like to see if anyone from the audience is interested in asking the panelists a question. We have a microphone coming around. Just raise your hand. Maybe have time for 2 questions. If not, I've got one. In the front row here.
Thank you. My name's Tina Kapoor. I'm from Radiology at the Brigham. It's very interesting to hear you talk about moving to blood-based biomarkers, when in an oncology discussion yesterday, they were talking about moving away from blood-based biomarkers to saliva and urine, so other fluid biomarkers. So what could we just leapfrog and just go to saliva and urine?
Yes.
I mean, I'll take this from a pathologist's point of view. It's sort of wherever your sensitivity and specificity is likely to yield the most useful results. I don't think we would a priori say you need to go in that direction, you need to go in that direction. Certainly ease of access does drive things like saliva testing. And so just from a diagnostic perspective, I'd say, well, if you could find out the same amount of information, same type of information with the same sensitivity, specificity from saliva, it would be absolutely wonderful. Yeah.
I'll also just add that a lot of genetic testing is now done with saliva. The failure rate is slightly higher because of the contamination, depending on how well people have washed out their mouth before giving a sample. But overall, we sequenced thousands of genomes with saliva samples. So in addition to biomarkers, you can also get the genome.
Well, one thing I'll just quickly add, an area of my research is on somatic mutations and their role in cardiovascular disease. And there's this larger effort funded by NIH to understand the spectrum of somatic mosaicism across the body. And among these projects that we're working on is how much can we detect just purely from saliva and urine of what is going across the body for these pre-malignant, precancerous lesions. So it's a little TBD.
My name's Alex Hannum. I'm probably the dumbest guy in the room. I'm the CEO of an executive healthcare center. I have 2 parents who died from Alzheimer's. I have some cardiac risk as well, because I went and did one of my own medicals, which was dumb of me to do. My question would be is, you're talking about screening as early as in the 20s for cardiovascular risk and potentially for Alzheimer's, which is obviously very important to my clients. How do you, obviously you don't want to put people on statins and drugs in their 20s. How do you motivate them to make that lifestyle change? And what has worked and what doesn't work? Because I know that there's always challenges to get them to that next level.
Yeah, so one thing I'll say is some fraction of those individuals probably will be appropriate for statins early on, depending on how abnormal the risk factors are related to lipids and potentially based on polygenic risk scores. And there likely will be other potential pharmacotherapies. Something like statins at least have been around in widespread clinical practice for decades. So it's maybe a potentially safer prospect. But as you say, the biggest part is lifestyle modification. The major challenge is, patients are very activated, they're interested in this, but the level of evidence that gets reported in the lay press is of very low quality. It's largely in the form of, what did people eat, and then follow them for 20, 30 years and see if there's cardiovascular disease outcomes. And there are many reasons why people choose to eat the things that they eat, and then oftentimes they're avoiding other foods as well too. So it's very hard to interpret that data. So we spend a lot of time just talking about the quality of the data, the things that they're reading out there, and then a higher level of evidence in the form of randomized controlled trials. Doing these kinds of outcomes-driven randomized controlled trials for lifestyle interventions is really hard to do, and so there aren't that many. So we focus our efforts there, and so that is also why guidelines haven't really changed all that much. We have a trial on the Mediterranean-style diet. That was about 10 years ago. That was probably the biggest innovation for lifestyle, but it's complicated. We are using a lot of things like wearables that are capturing actually what patients are doing out there to have more granular metrics on how they can advance. But we use nutritionists, exercise physiologists. It's not a one-size-fits-all for sure.
So with that, I think we are now 2 minutes over, and sadly need to get going and give everyone a chance to get to their next panel. But thank you everyone for joining us for a very spirited discussion.